Now, this is very important. We are using 3 different types of guide wires here. First of all, through the percutaneous catheter, we are using a hybrid JAG wire. The second wire we used to get into the right anterior duct was the Biciglide 2 wire. The third wire we used is an interesting wire called the grip wire. So, the first thing we are going to do in this case is to do a radiofrequency RFA ablation of the strictures. We have to do on both sides, left and right. There are 4 electrodes here spaced 3 millimeters apart. It's a bipolar catheter. The current goes from one to another one, creating this bipolar energy, thermal energy. We have placed these 4 rings at the stricture in the left hepatic duct. It's important to place it in this area and not move it when you're doing the procedure, because the heat is constantly being generated there. You get about 2 centimeter depth of thermal injury. We start the machine now. The resistance is at 51, the impedance is at 51. So first do an radiofrequency ablation of all the posterior and anterior segments, and after we did that, we did a balloon dilatation using both Titan and Hurricane balloon. We dilated the left duct and right anterior and right posterior separately, because this is very important. The right posterior was very tough. We put in 1 stent while waiting for you, and this was on the left duct. You can see we put an evolution stent. And it's important, if you get the endoscopy picture, that the lower end is actually outside, just outside the papilla. This is important because if you want to recannulate again when the stent gets blocked, you must always have it outside the papilla. The second stent I'm going to put on my wire, this is on the right anterior duct, and I'm going to use a wall flex uncovered stent. And you can see that as the stent goes in, there's a little resistance because already we have one more stent in place. So this is going to be a little more difficult, but the third stent is going to be the challenge, which I think you'll have to watch that. But first let me see if I can get this stent in. Now what I'm looking at is the lower end, because I want the lower end to be just outside the papilla. Can you now, Ralph, open the stent? Yeah. Ralph is going to open the stent now. Okay. Now what I'm doing is I'm not concentrating on the top part at all. I'm concentrating only on the endoscopy area to see that I place it in the right way. And I'm just constantly checking that because the light is coming. Now, yeah, now you can go down. The fluoroscopy can go down, show us. So when I come to the second lower marker, I'm going to put everything in position and then ask RAF to completely deploy stent. So keep deploying RAF now. This is very important that they're all in the same position. Okay, now we have deployed this stent. I'm just going to see that. See now both the stents are outside the papilla. Now I'm going to take out the stent along with the guide wire because we don't have any need for the guide wire. Now this is going to be the challenging part, the third stent. Now you can see this going up now, the third stent. I'm going in, and as it's going in, I'm just trying to feel for it. This is where the resistance is. So I'm going to use a little screwing movement, jiggling movement to get it in. And it seems to be ascending a little, and I'm finding it a little difficult here, and RAF is pulling on the stent actually, and that's why it's going inside. Otherwise it would have been extremely difficult to get this in. I'm just pulling it further. Yeah, further. Excellent, excellent. Got through. See that? We are deep inside now, and the reason, the way it was pushed in was, in spite of the tight stricture, we used a couple of endoscopic movements like little screwing movement, jerking movement, and RAF was the torsion was simultaneously pulling on the JAG wire here. So this combination, this is again teamwork, very important. This combination helped, and now we are going to release this stent. So I'm just now looking only at the endoscopy picture because this is very important. The 3 stents should be placed parallelly so that when you want to recannulate, and which is likely in this patient is going to live long enough for that, you will have to recannulate all the 3 stents. Yeah, keep push, RAF, keep. Yeah, okay. Now the third stent, you can see all the 3 stents now. Can you see that?
Yeah, we
Thomas?
can. Very nice.
Thomas, you are satisfied?
Keep the wire. Keep the wire.
Yeah. So what is important is that we are keeping the wire in place and then removing this outer sheath only. Now as torsion is holding on to the catheter there, I'm going to pull back on the wire. Yeah. Yeah, the wire is gone completely. You can pull back on the catheter now. Okay. Yeah. He's going to pull back the catheter completely. Okay. You can see very good drainage now, and it's a perfect procedure. So I don't think we require in this case. We can remove everything now. Okay.